So to follow on the same topic, I will now give the floor to Priscille Sauvegrain, who is a midwife at La Pitié-Salpêtrière, a large hospital in Paris. Hello. Hello. And a researcher in public health in the in an Inserm Université de Paris research group, the épopée team at the CRES. She has worked for several years on factors that are associated with women's perinatal health outcomes, which James Nasrou already mentioned in his talk. So she will talk in some detail about the data that we now have about the immigrant women's access to healthcare and also their health outcomes in the context of pregnancy and childbirth. And her research is very much based on public health and sociological approaches. So she uses mixed methods to conduct her research. She's also chair of the scientific committee of the Collège National des Sages-Femmes de France and a member of our Department of Health at the Collaborative Institute on Migration. Thank you very much, Priscille, and the floor is yours.
Thank you very much, Maria, for this nice introduction, and thanks to invite me to this table with James, Matthew, and Francesca. It's an honor. Hello, everyone. I'm going to present you my work. We are already going inside the healthcare system and inside the healthcare relationships between caregivers and their patients. And my research are exploring the hypothesis of discrimination in perinatal care in France with the example of African women. Next slide. So on a conceptual way, I'm really much working with the concept of differential care as described by Didier Fassin to varying access to care for foreigners, but also varying levels in their follow-up, conducing most of the time in less quality of care. It's important to do this distinction in differential care between the ones who are clinically justified, and I'm thinking here of the screening of sickle cell anemia, la drépanocytose, depending on the place of birth, and the unfunded medical care. And in this presentation, we are in the way of unfunded medical care, unfunded differential care. Next slide. So, the empirical data which are supported these theses are first, European one. Sub-Saharan African women, I'm going to call them SSA women for the rest of this presentation, are constantly shown as the most at-risk group. They have, James thought he told it before, an excess risk of maternal mortality. In France, this risk is very rare. We have only around 80 deaths by year, but the risk for SSA women is multiplied by 5. And this data is found also in the same proportion in Switzerland, UK, and Sweden. In France, around 24 births are from foreign-born mothers. 6% in SSA, and all the last studies are congruent. They are the most at-risk group women. They have more frequent inadequate follow-up. They are most higher rate of maternal morbidity, and they have also suboptimal care, which are found in a higher proportion than French women. Next slide. So my doctoral research was on medical trajectory of African perceived women in public maternities in Paris area. The methodology was very basic: in-depth interviews with healthcare providers, interviews with women, and also participating observation phases in the maternity I was working in. Next slide. Those are the main results of this research. It was conducted 10 years ago, to be clear. So the context has a little bit changed. I will conclude with that. But based on identification of physical differences, so mainly the color of skin, a description of problems and facilities they offer in their trajectory of care, but also a big assumption of cultural differences, which were not asked in the interview grid, but I have a huge amount of verbatim who are describing these cultural differences. We really shown a category emerging in the discourse of these women, very different from the others. And the healthcare providers, for example, describe less use of prenatal diagnosis. They all said they are giving birth better, and that's a really interesting point because they are actually the group who is the most facing C-section in France. And it's around 35% for them versus 20% for the rest of the population. So it's a big difference, and it's completely obscured in the discourses of the healthcare providers. They also said they are all breastfeeding. Next slide. Let's go now inside a discriminatory protocol. It was called the Ethnic Term of Pregnancy Protocol, and it asked and it encouraged to follow the end of the pregnancy of this African woman 1 week before the others, and so to induce the labor also 1 week before. And depending on the maternity, sometimes the Caribbean women were included or not. Sometimes the girls were included or not. Sometimes the Indian woman, sometimes the Pakistanis one. And this was completely depending on the maternity. In 2011, the National College of Obstetricians just indicated to end this practice. If we look at this protocol with the sociological analysis, we could first say it's a misuse of the term of ethnicity. We are purely in racialization. Second of all, it was no authorization from ethics committees to apply this protocol. It is not a single evaluation in this protocol, so you cannot find a single article justifying this practice, and it was taking over 10 years. And on the top of that, women were not informed that they were included in this protocol. Most of the caregivers, they described that, okay, I said to her, like, please come this date, and the woman was coming. And nobody explained her that you are taking in care 1 week before the others because we think that your end of pregnancy is more at risk. And so we are giving to offer you a special survey because of your color of skin. Okay, next slide, please. So this really raises the issue of discrimination. And again, as said the others before me, at the individual level, but also at the institutional level. It means the hospital doesn't protect its users to these things of protocol. Next slide. But beside these discriminatory protocols, we have to say that the health caregivers in maternity have very, very strong positive stereotypes among African mothers. It's like an African mother figure. The way they are giving birth, the way they are breastfeeding, their lack of depression in the postpartum period were really applauded. And in their opinion, the woman also appreciate very more our French system. They said it's clean, it's free, it's safe. And the healthcare providers are very polite with us. So comparing with experiences in Africa, they are really not considering to be discriminated in this care system. So beside the both positive stereotypes of the caregivers and of these women, the work of Strauss and his collaborators let us know how much these representations are funded with explicit stereotypes and also implicit one. Next slide. So it gives us the idea in my Inserm team to work about the implicit bias of perinatal healthcare provider in France. It's a huge amount of literature in the US on this subject of implicit bias and effect in health. And this is the citation of this subject in PubMed those last years. Please, next slide. Oh, please, maybe next slide, because it's not complete. Oh, okay, sorry. The previous one. Okay, I'm sorry. So we, with Professor Elias Ria, which is coordinated this project, we organized a big project called BEEP, Implicit Bias in Perinatality. And we include in this project sociologists, epidemiologists, psychosociologists, and clinicians. And we explored in these three ways the risk for the patients to be exposed to the implicit bias in their perinatal trajectories. Actually, this project started 2 years ago, and we are in the analysis, and we have really a big work to fix these three parts all together. So I'm sorry, I'm not going to present any results here, because to be really sure of the impact of this implicit bias among migrant people in perinatal way, we have to wait a little bit more. So I will go to my conclusions. The various aspects of discrimination we describe here are not necessarily intentional. I mean, the healthcare providers, they want to be good. They want to be good in medicine, and they want to be good in the way they are taking care of their patients. So we are really, when we are coming back with these results in front of healthcare providers, they are really like shocked and in resistance with that. But I really think it's time to go over that now, because stereotypes, ideologies, bias, and discriminations found in medical staff can be, I'm sure of that, successfully eliminated through specific education first. We are not, during our studies, very, I'm sorry, it's a chat. We are not aware about these sociological issues. We are not, we don't have any tools to deconstruct the stereotypes, and we are hearing them every day at hospital since we are 18 years old. So it's not a good way to deconstruct them. That's first, very important. Second point, we have to establish now relevant protocol. It's time to successfully eliminating unfunded differential care in both access and follow-up, because now are arriving in France a slew of women which are broken during their migrant trajectory. I mean, their mental health is affected. Their physical health is affected. So now we have to stop to be colorblinded in France and just consider what is the exact risk of this woman, the maternal risk, the perinatal risk, and how can we go over this risk. This is essential for equality in health, and at least 2 generations are implicated. Thank you for your attention.
Thank you very much for this great presentation, Priscille. Indeed, we're looking forward to the results of this study to shed light upon some of the unconscious mechanisms that also are at play when doctors receive their patients and decide on how to treat them.